Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast.
Hi, everyone. Dr. Eric Westman here, and welcome back to my YouTube channel where I review and debunk nutritional information online and get to interview amazing people in the clinical keto, low-carb world, and that's what I'm going to do today. Welcome to Matt and Laura. Thanks for being here.
Thanks for having us.
Thank you. Excited to be here.
Well, I have to say you're the ones that are going to take this home, meaning the knowledge, the spreading of the information. That is, if Raven Simone doesn't do it first. She, the Disney star Raven, that's so Raven, actually most of you watching probably have had children or grandchildren watch this show, but she's actually been pretty vocal about her keto journey. And so maybe she is going to, I'm sure she affects more people in that demographic than I do. But anyway, in the medical world, I really see you two as leaders to train, to teach, to spread, and not to, put too much burden upon you, but to help change the world. So thank you for what you do. So let's say nobody knows who you are. Who are you, and where you're from, where you went to school, and it's kind of amazing that you're both doctors in training. They're so young these days, these doctors. Who wants to go first?
I'll start. So I grew up in upstate New York, went to undergrad and then med school in Florida at University of Florida, and I always had a passion for sports, and that passion for sports kind of grew into both sports and then nutrition later on, really into medical school. And we had a 2-week intensive on nutrition that was really underwhelming, like you probably have commonly heard from a lot of doctors who've had nutritional training in medical school. And it was same stuff, saturated fat's going to kill you, and then common deficiencies that you've got to be able to catch, vitamin C deficiency and scurvy. But not much more than that, nothing practical about how I could help patients. And so around that time, I started doing a lot of just research on my own, came across Jason Fung's The Obesity Code, Low Carb MD podcast, yourself watching lectures from Low Carb USA. And it was just, my eyes were opened, and clearly our guidelines, the national U.S. dietary guidelines, have led us astray. And I changed the way I was eating. I had avoided red meat for almost a decade. And going into residency, I decided off the bat, this is how I'm going to practice medicine. And I did, and it was wonderful. And after some initial conflict or just more debates with my attendings or faculty about how I was practicing, they were wonderful and saw the results that people were having. And then they stopped giving me pushback. So I was able to continue practicing low carb, and they're very supportive, and everyone was always very friendly environment.
So in your residency training?
During residency training. So initially when I would try to order calcium scans or fasting insulin on patients, it's kind of like, well, why do you need to get a fasting insulin on this individual? Their A1C is 5.5. How's that going to change management? And so that it would be talking to them about insulin resistance, early stages, trying to educate patients before pre-diabetes develops, before diabetes complications occur. And then for patients who came to me with an A1C of 10, guidelines say you should start them on insulin. Instead, I would say, hey, why don't we put a glucose monitor and work on low carb, ketogenic eating? And if they wanted to avoid medicines, they jumped on board, loved that idea to avoid the insulin shots. And then I'd see them back, track their glucose, and their A1C would normalize or get significantly better, drop into the 6s with no medications. And so once you start seeing results like that, you're not going to get pushback. That's amazing. And so I have to mention, part of the things that I actually used during residency was with my rotation that I actually came and worked at your clinic and kind of shadowed and saw how you worked. and I actually started using your handouts for my patients, and it was hugely helpful. And I mean, in 1 week at your clinic, I'm going to be slightly off, but it was around 1,300 pounds of weight loss among the 38 return patients we had.
I think you were making some notes.
Yeah, I mean, it was just incredible. I hadn't seen results like that. There's over 30 medications stopped during that 1 week, and those individuals, and it was just it was so exciting. This is medicine.
Well, let that be, I guess, a testimonial for other residents or trainees at any stage that with the right kind of teaching and monitoring, you could even influence your attendings. And of course, you always want to do that, diplomatically. But one reason that I stayed in academia was to be able to learn from trainees who come in asking questions, and even just you're always being asked why, and I have always found that to be helpful to improve what I do. So that's great. Remember the handout that I got was really taken and modified from Dr. Atkins, who had worked on it for 30 years. So we're just kind of using a low carb method that at the end of the day is simple, right? I mean, that's important in how you do this.
Yeah, absolutely.
So in your clinical practice, would you say people were highly motivated or kind of coming in? Sometimes it's often like a bait and switch where, I thought I was going to get medicine, but you're telling me about food. What is the uptake in your experience for your patients?
In residency, maybe 50%. Yeah, it's hard to really say for sure. And you just, because of the nature of the clinic, you end up having less follow-up. So there were a handful of people I could follow up monthly and did amazing. And Matt actually, because he was 1 year behind me, and he'll tell his story, but I handed off quite a bit of my patients to Matt that were continuing low carb, and I knew they would be in good hands with them. And now where I work, so I work with Dr. Tro, people are coming to us knowing that we're recommending low carb as our primary intervention. We still use medications and do what's right for the patient, but primarily we're trying to help people get off of medications and using lifestyle changes and using low carb.
And so describe the practice that you're in right now. It's pretty much all telemedicine. Is that right?
Yeah. So it's exclusively telemedicine, licensed in almost all 50 states. So we see people from everywhere. And there's a couple different programs. One is more of an intensive 6-month where you see either myself or Tro with a health coach, and you're having weekly appointments and just a ton of touch points, back and forth visits. We're remotely monitoring with glucose, CGMs, so continuous glucose monitors, scales, blood pressure cuffs, sometimes ketones, depending on the individual. And then there's also more of just a kind of virtual metabolic care. So it might not be that intensive 6-month program, but you're just following me basically for primary care. But again, knowing that I'm going to be focusing not just on your cancer screenings, but all your other metabolic health needs, and how can we help you age well, avoid chronic conditions rather than just start treating them once they show up.
Great. Yeah. And I saw Dr. Kalajian, Dr. Tro, and it's drctortro.com, right?
Yep.
Doctor spelled out drtro.com. I saw him give a presentation about the program. It's fantastic. In fact, it's probably one of the only ones created by a doctor who had issues himself. So he understands that if you're not checking in, you might have relapsed, or the vigilance. I think I haven't seen that so much, even in my practice. If there's this chatter that people have in their heads the week before, that do I go back to see them or not? Do I go back to see the doctor? He's going to be so upset because I haven't been perfect, and I know if you could have that sort of touch, that's great. But now it's for not insurance pay yet, right? It's outside insurance.
Exactly. It is outside insurance. The other way that we, again, it's not really through insurance, but we work with employers. And so we have an employee wellness program. And
Right.
I love this because then we're getting all levels of socioeconomic status. People are, in that instance, a lot of the employees we get, we do tell them what we're doing, but they're not necessarily seeking us out the same. But yet they still have amazing results. And so we're actually working on publishing our 1-year data for one of the companies that we're working with. And it's on about 50 patients and average weight loss, 40 pounds, while deprescribing almost 100 medications.
Yeah.
So it's exciting.
Fantastic.
Yeah.
So I guess if someone's watching this, wondering how they could get involved, they could go to their employer and say, hey, why don't you partner up with Dr. Tro and his group? Yeah, even if you can't afford it individually, maybe any company that's self-insured ought to be on top of this, because any money you save will be saved right there. You're not paying another insurer, right?
Yeah, and the cost savings through the medication deprescription is almost $100,000. So medications cost so much money these days. So employers take the hit on that.
Well, and what's almost kind of unbelievable is that not only are you saving money, your people are getting better. So this doesn't compute. Usually it's how much more do I have to pay to get someone better? And here what's happening is, no, people are getting better and you're saving money as the system. I have to imagine that's why most people don't believe it. Usually how much do I have to pay? No, you're going to save money by then. That's fantastic. Now, when you came to the office, I think you were wearing a continuous glucose monitor. And I thought that was a bit odd, a bit strange, or maybe just way ahead of your time. Are you still wearing a continuous glucose monitor?
Most of the time, I haven't had one on for about a week right now.
Wow. I haven't had one on since you were here. So, or it was when Matt came to the clinic, I put one on. So do you watch your carbs personally yourself?
I do. Yeah. I am always low carb, often in ketosis. I don't check ketones as much that more just because the finger prick, and I just stay very low carb. So I don't really worry about it. I don't have a medical condition where the higher level of ketone, it's necessarily extra beneficial for me.
Well, but didn't you just have a baby? I mean, recently.
I did. He's 11 months now, but he still is. During the pregnancy, I was low carb, definitely in ketosis for part of it. And I've been breastfeeding this whole time, and same thing. And low carb keto, I even did carnivore just for some interest because I was testing my breast milk in the past few months. There's a lab that will actually test the macronutrients and some of the micronutrients in your milk. And so, interestingly, from going my moderate carb to low carb, keto, then carnivore, the number of calories per ounce of milk increased. It was much higher than kind of the average formula is about 20 kcals per ounce. And so mine went from about 23 to 27 to 30 calories per ounce on carnivore.
Well, it kind of makes sense, when you think about it. And just for those watching, it's okay that someone didn't eat carbs during pregnancy. I know if this is the first time you're hearing this, I was introduced to this in my trip to Indonesia some years ago, where the doctors were telling me about the keto babies, the moms who were not eating many carbs and they would fast during the day. And they even said their keto baby that they have followed were developing great, even maybe better than before. And then I come back to the U.S. and it's just such a strange, but they're on Facebook and I'm connected to them every day. That's Keto Fastosis Indonesia. But then the type 1 grit pregnancy book was published. This is experience of a lot of people with type 1 diabetes who choose to eat low carb and have babies as well. And so in your read of other, just watching what other people are doing, is this more common, and I assume you had a good experience not eating carbs during pregnancy.
Yeah, it went very well for me. I never had any issues. In my first trimester, for a few weeks, I had significant carb cravings, and I did have a little bit higher carb at that time. Added like a little bit of sweet potato and fruit until the cravings went away, and that was, again, it was just a couple weeks in the first trimester. Besides that, played tennis. I played tennis until my 38th week of pregnancy. I played competitively till my 32nd week, and was feeling great. And James, who's my 11-month-old, is thriving. He's doing really good, very strong, energetic little guy.
Well, and was your family supportive all of this time, or because now the grandparents have some vested interest here.
Yeah, fortunately, all of my family is either eat low carb themselves or just have listened to me enough about the science that they are supportive.
I remember hearing a professor of obstetrics in Chicago came to one of our obesity meetings, and he basically said, I'm measuring the baby with an ultrasound. He said, I don't care what you do with the mother. It's okay if the mother loses weight and all that, but because I'm going to be measuring the baby as long as the baby is growing. And of course, that's with monitoring. And but thanks for sharing your experience. I'm sure there are others who are interested in, especially if you have PCOS and you've gotten pregnant because you did low carb. A lot of my patients will ask, well, then what should I do? 10 years ago, I would say, well, you better add back some carbs and avoid that terrible thing called ketosis. Sarcasm here. We all go into ketosis after 2 days of not eating anything. I'm becoming to think, this really may be the intended metabolism, and Steve Finney is the one who's talked about that for decades. But interestingly, you said that you don't have a medical condition that would require, or probably measuring ketone levels would be more beneficial. That was interesting little insert there. What conditions in your experience should people be monitoring ketones?
Yeah, so there's definitely some mental health conditions such as schizophrenia or bipolar where individuals notice that maybe their symptoms resolve entirely, but it has to be maintained at higher level of ketone, similar to some individuals with epilepsy, where they have to keep a higher ketone threshold for the benefits. More recently, this is just anecdotal. I've had some patients with lipedema who notice improvements with higher ketone levels as well. And then, is the higher the ketone level, they say the leg pain or just the pain that they can feel sometimes throughout where there is lipedema is improving, and then the inflammation and even the swelling that will come along with that all improves at the higher level of ketone. I've also had definitely some depression, anxiety, acne. As recently, I've had 2 different people in the past few weeks whose acne significantly improved. That, I guess, was not a specific level of ketone, but just in ketosis, it was very noticeable.
Yeah, the acne, the skin conditions pretty much all improved. Psoriasis, even though the published literature is way behind on that. Awesome. Well, Matt, do you mind if we switch gears and you guys are related in some way, right?
Yeah, if you talk to Laura, you've talked to my greater half. She's we met right before med school started and started dating soon thereafter, and then got married in our 3rd year of med school while we were on our psych rotation. Basically got married on a Saturday, and then on that Monday we went into the psych rotation, and the attending said, "Well, what did you guys do this weekend?" We said, "We got married." He's like, "Oh, that's a first." So that was fun. But yeah, we met in med school. And I'm kind of the same way as Laura. I was active growing up. I did a lot of weightlifting, played football in high school, and then continued weightlifting through undergrad. Decided on med school really late in undergrad. I was like a super senior doing my biochem class, and then got into University of Florida med school, and pretty much gung-ho from the beginning, actually, going into emergency medicine, which is where we ultimately matched. We met couples matched family medicine for Laura and emergency medicine for me. But really, we got interested in just the metabolic health aspect kind of around our 3rd to 4th year of med school, which is really close to the time you have to apply anyways. And I was already thinking, wow, this is like what I want to do. When you're going through med school, basically you're commonly taught, and it's reiterated, that obesity is a chronic progressive disease, diabetes is a chronic progressive disease. And at some point they take the joy or the fun out of like practicing medicine because they're just so negative all the time. They being just the standard of care guidelines. Like in general, a person's A1C will increase by about 1% a year. So you'll have to go on a new medicine every year. And then eventually you're on insulin. And then eventually you're on dialysis or things like that, the end stage complications of diabetes. But we went to, started listening to low carb, and went to this small low carb conference called Low Carb Boca, where there was a well-known speaker, Dr. Eric Westman. And it was enlightening. It was the first time we've actually heard where diabetes doesn't have to be chronic and progressive. You can actually look up the American Diabetes Association website, and they do say diabetes is chronic and progressive, but obviously that's not true, because there's now hundreds and thousands of patients that have put their diabetes into remission, and we have data that supports that. So I really think this is the first generation of medical students where, there was still kind of a saying like, oh, patients don't want to do the lifestyle thing. They just want the medications. I find that's actually not true at all. Every patient I've seen does not want the medication, and I've learned more from my patients than they've learned from me in terms of figuring out how to help them through lifestyle alone. Ultimately, mashed into emergency medicine, I saw Laura basically bringing A1Cs down from 10% down to 6% with just cutting out the carbs and no other medications. I was like, this is what I want to do. I was so far downstream of the problem in emergency medicine, which is an amazing field. I have the utmost respect for people that do it, because it's one of the toughest jobs I think you can do. But I wanted to be 1,000 yards upstream, helping people not get into the river, so they stay out of the emergency department in general. And so made the really difficult, it's not to go too deep into, but it's kind of hard to switch residencies, actually. It's not like switching a job. You got to reapply, do all this other stuff. Never been a day where I haven't thought that that's the best decision, one of the best decisions of my life. And went into family medicine as well, was a year behind Laura, got to take care of her patients for next year when she finished training. And now I have myself kind of a in-person metabolic clinic, in addition to doing some urgent care over on the western side of North Carolina, with hopes to expand that in the future too.
Okay. Awesome. What do you think, switching gears a little bit, how do we expand, grow, amplify your message? Now, it's a slow process to just have 1-2 people come through, and where do we go from here?
I think we're doing it. It's really about reaching a critical mass of patients, of advocates, of providers, of physicians, of registered dietitians, mental health counselors. You learned from Atkins. Your story was amazing when we first heard it. You basically said, show me the data, and then you created the data yourself. You went through his files. And so Atkins taught you through the data you published in the early 2000s and the conferences you're putting on now are just basically it's the roots of a tree at this point. And I do think we've reached a critical threshold, because even the co-residents now, or used to be our co-residents and the residents that are still training, they know of low carb. They know it's safe and effective for many different chronic diseases. And we have a couple that actively practice this in residency right now, whereas it never happened before. We have, I would say, even before Laura and I were in residency, there's been 0 people at our particular residency. And now, including us two, there's at least 4 people. So 4 people in the last 2 to 3 years that actively practice low carb keto in their practice. So I think people that came before us definitely paved the way. Laura paved the way for me, because I never got asked about calcium scores or ordering calcium scores or ordering insulins. The attendings already knew. She already advocated that. Yeah. And so that's what you guys are doing, and continuing to put it out there, and it's just going to snowball.
Well, and it's reassuring to hear your optimism. and you know, I'm there. I used to be there. I wouldn't be here if I wasn't optimistic too. But you always want to try to get it spread as fast as you can. Creating the Society of Metabolic Health Practitioners is one way, right, of creating a group of people. And this group is not just for physicians, right? It's for any coach or professional that wants to help with metabolic health. What do you see the SMHP role to be? And I should say that, Laura, you're the secretary, right? I'm on the board of the SMHP. How can this organization help?
Yeah, so I think there's several different roles, and I'll also make sure Matt has something to say, because he is the head of the advocacy committee as well now on the SMHP. So I think we're associated now with the Low Carb USA conferences. They're now the symposiums of metabolic health, and so meeting people there, and training as well, young doctors, dietitians, health coaches, like you said. The people going to that conference are from all different jobs, or just people who aren't necessarily helping others, but they just want to learn. So I think getting the message out through conferences. On the website itself, there's a doctor or provider search bar that you can actually go try to find people in your area that can help you if this is something you're interested in, but your doctor isn't open to low carb, which is a big struggle for a lot of people, actually. So that's a really helpful resource. And Matt has actually created a PowerPoint that is now on the website, where other doctors could take the PowerPoint basically as a pitch deck to their clinic and say, hey, here's the evidence that low carb is not only safe, but extremely effective. Can we start implementing this in our clinic? And the other really exciting thing I think that the SMHP has done is it now has its own official journal, the Journal of Metabolic Health. And that is going to be extremely helpful for getting more research on low carb, keto out there more quickly, because there definitely is, unfortunately, a bias against low carb keto. If you go to some of the mainstream journals, you see it time and time again. And so this is going to be a journal that is not going to be biased. You still have to go through the rigorous peer review process, but they won't have anything negative going against you just for writing data on low carb. And we could actually spend just a couple minutes, although do you want to talk about what was recently published? And
one more thing I would say is that the standard of care in medicine is more or less sometimes based on guidelines. Standard of care doesn't have to be guideline based, though. It's just what is a reasonable thing that other physicians do in a situation. So I would say now that the standard of care is actually low carb ketogenic diets, because we have a preponderance of evidence. We have a lot of physicians that practice that way. And so if they're basically, you can point to these articles, but we also published a guideline through the SMHP about therapeutic carbohydrate reduction. And that is just one more piece of evidence that it is the standard of care. To Laura's point, you helped us publish, you were one of the co-authors on this paper that we published fairly quickly through the Journal of Metabolic Health, which was excellent, because the turnaround time on these things does have to be fast. Otherwise, you kind of lose the momentum. There was a paper published for your listeners last year from the American Academy of Pediatrics on low carbohydrate ketogenic diets and type 1 diabetes, pediatric, meaning children less than the age of 18, type 1 diabetes, type 2 diabetes, and at risk of type 2 diabetes, which means obesity. So that's a very large swath of the pediatric population that could be helped by low carb diets. And their essentially their conclusions were it's effectively unsafe to do without very close medical supervision, which they kind of, if you read the table, they recommended 6 different lab draws over the first year with 14 different measurements trended, including if you've been on a ketogenic diet for 2 years, you should get a DEXA scan as a child. Yeah. So we went through as all of the authors, and we really read through their paper, and we highlighted, I think, the errors in thinking. And I think at least it was helpful to publish it in the Journal of Metabolic Health because we got it out there. We actually first made comments on the paper because the AAP, which it was published in the AAP's journal, said, we will, if you comment, there's a chance we might publish it as an editorial. And that's what we were hoping for. It was pretty much silence. So nobody responded, nobody said anything. And so we really had to take matters into our own hands and publish our rebuttal.
Yeah, well done. The idea as quickly as you can to realize guidelines are human. They're based on people's best decision, and if it's totally off base like that one was, to make a correction of it is well within the scientific realm. In fact, it should be welcomed. That journal should welcome the feedback, and that's not what happened, which is a sad state. Of course, 25 years ago, Richard Feynman, the other, not FEY, but FEI, came to me and said, we need a new journal called Nutrition and Metabolism. We need to start a new one. And I said, can you do that? And he explained, yes, it happens all the time when peer review gets so echo chambered and you can't get a fair peer review of a keto diet back then called low carb. This happens all the time. You just get a new set of reviewers and you follow the similar you follow rigorous standards of review. It's just you don't have that preconceived, prejudiced notion, bias. So it's kind of sad. Some articles won't be accepted even when they have legitimate criticism. So I'm really glad that you're learning that at this stage. Of course, being as diplomatic as you can. My colleague, Will Yancey, and I'm sure in Florida, the saying is, you attract more flies with molasses than vinegar, so not that we want to attract flies, but it's better to be diplomatic about it. And I think the SMHP will have a forum for guidelines so you can cite them. You can the PowerPoint downloading, so that if you're a physician and you want to do a presentation at your local clinic, or you're defending yourself if someone's giving you a hard time, the SMHP will have those resources, and that really hasn't ever been available. So thank you so much for your help there. How about the medical education in schools and residency? I think you guys were working on a course, and which it was a heroic effort. What's the status of that?
Yeah, so our friend Erin Sayer, she's also a physician, went to residency with us, was a year ahead of us. She has actually stayed on as faculty at Wake, and she really helped us with that course as well. And we did have a couple other residents take it. She is working on creating a longitudinal nutrition course, obesity medicine or obesity course, basically, for residents. And that, because of having worked with her on the other course, I think hopefully she will do a phenomenal job. And then that will be implemented at Wake. And she's definitely going to show the evidence behind low carb keto. And I think she's probably going to be showing some of the other evidence as well, or lack of evidence for certain things that are commonly talked about. So reviewing the dietary guidelines and what evidence was there to really put those forward. So I'm really excited to see what she comes up with. She's dedicating a ton of her time now to that course. And so we'll probably be giving some of the lectures and just assisting with her on the side. And then, depending on where that goes, maybe the SMHP could be involved or help with it spreading. I'm not sure where that will go, but I'm open.
Awesome. And, any sort of experiential feedback along the way is often very helpful. I've even seen that some med students put CGMs on themselves for a while and wrote a paper about their experience. So I wanted to, that's fantastic. And so it's not ready for anyone else to pick up and use at the moment.
Not ready yet, but we're hoping we'll get there. And I think, I believe actually, and I won't ask you on the spot here, but she was thinking of potentially you and some other, maybe Dr. Mark Cucuzella, some other people giving presentations as well that could be included. And
I'm happy to do what I can. Yeah, Dr. Yancey here is also, Will Yancey is rising in the academic. He's acting chief of general internal medicine at the moment. And it's always nice to have someone in that kind of position to help with the education process. Fantastic. Well, so I remember, so practically switching gears again, what have you learned by wearing CGMs or a continuous glucose monitor through the years? And if someone's watching and they don't know what a continuous glucose monitor is, how it might be helpful, how do you see them now?
Yeah, go ahead.
So yeah, when I explain a CGM to a patient, a continuous glucose monitor, I basically say it's a quarter-size device that sits on the back of your arm. Most of the time, sometimes it goes on the belly, but it essentially gives you real-time feedback about what food is doing to your body. So in the old paradigm, you would make a lifestyle change here, and then you would try to measure your weight daily, and then try hopefully to trend out what that lifestyle change would do to your weight. Problem with that is there's going to be weight fluctuations because of water weight. Are you overhydrated, underhydrated, and any number of things which could possibly derail and demoralize you. But when you eat a food and you check your sugar on a CGM, you will know immediately whether that food was on your low-carbohydrate ketogenic eating plan. And I think that's actually more important now. It's actually important as it was ever, because these food companies are very sneaky. They will kind of inject or just kind of hide sugar in many different foods. My personal story is, you're not going to like this, Eric. So during med school, I would go on my vascular surgery rotation, which is a very intense rotation. I would have to get up at 4 and be at the hospital at 4:30 for rounds. This was pre-low carb days. I was eating these healthy oatmeal bites, and basically the box said all of the right things: non-GMO, low carb, in fact, high fiber, omega-3s, all of these things. And if you look at the back, it said that the front said the net carbs are the net carbs are like 2. And you look at the back, and there was about 15 grams of fiber and 17 grams of total carbs in those cookies. And I was like, oh, these are great. There's 8 cookies in a box. So I would eat like 4 of those before, as I was driving to the hospital, kind of still almost like very tired. Basically the only thing I could eat before I get there. And I started to put a CG on during that rotation, and those cookies were actually spiking my sugar to 180. 4 cookies. Yep, 4 cookies first thing in the morning. And so you realize quickly that you're getting fed this information that is not correct, and it's not good for your body long term. If I kept eating those cookies all the way up through today, I don't know how long the body can really sustain a reaction with sugars going as high as 180 and 190. There's a lot of chatter nowadays about what is a healthy glucose excursion, but I don't think anybody would say that a sugar spike to 190 from 4 cookies is actually a beneficial thing.
Oh, we have medicines for that.
Yeah. I mean, eventually I could have used metformin and then all of these other things, or even a carbos, and that can like bind to the everything. The other thing it shows you is that these food companies will create metrics to make their food seem better. So the idea of net carbohydrates, one of the things that trips up my patients the most are keto breads or low carb breads. and they basically ultra manufacture these foods and just push as much fiber in there, which is digestible, and it does raise sugar into these foods, and then they try.
But it's called not non-digestible.
Yeah, it's non-digestible, but it will still raise your sugar, and and so they still see their sugars going up to 200.
So it's not just me that says use total carb, not net carbs. It's not just me.
It is a marketing tool by the ultra billion-dollar companies to sell people bad.
And as Ian Berger, who helped write End Your Carb Confusion, told me years ago, it says, and I repeat, there's no keto food. Keto is the metabolic state achieved by lowering the carbs. So I even saw a coffee bean laced with some MCT on it, and they called it keto coffee bean. It must be a trivial amount of So the total carb, net carb, the fiber bars, the raising the blood glucose. But so have you become an obsessive biohacker and you get upset when your glucose is over 100?
Personally, I don't even wear CGM anymore because I just stare at a flat line all day. Once you know what your body is doing to your food, and I think the low carb is liberating because I enjoy food, like I enjoy eating, but it's never something that I think about. It's never something that I don't have cravings. I can eat the same thing every day and it's still incredibly satisfying to me, but that just allows me to know what food is doing to my body.
Well, so how many years, Matt, did you wear the CGM?
About 4 to 5 to get it.
Yeah. Well, I'm just trying to, for those of you who are watching, who are enamored with the CGM and maybe even using it to get off the medicine. Once you see the same thing over and over and over, it's okay to stop using the CGM. But anyway, I joked about that. And in fact, you got me to wear one. Well, I wore one while you were at my clinic, and I ended up with a higher glucose at the end because I would test. I wonder if I could have this. I could have it when I just stayed at the page 4 list of, the keto list. Yeah, I was 80s and 90s. And then, but the day to day, then you also learned that exercise will raise the glucose hormones, the dawn phenomenon. There's a lot of worry that can be brought into this by measuring it, right?
Yeah, I think you just have to be aware of what is normal and what you might see. So don't get worried about the glucose spike from exercise. That's totally fine. So as I think just making sure someone has the proper education so that they actually say don't stop exercising because they're doing everything they can to keep it a flat line. But usually I really haven't come across it causing eating disorders, which I've seen people claim on social media. We don't claim that measuring someone's A1C is causing an eating disorder. So it's a silly argument, but it like Matt said, especially when you're first starting off making those lifestyle changes, it can be incredibly helpful. And then sometimes just seeing how not only what you're eating, but the stress in your lifestyle or the stress that you have, poor night's sleep. I've had a couple of patients, not common, but a few people who really respond to caffeine, like significant response.
Raise the blood glucose after caffeine, yeah.
Yeah, quite a bit. And to the point where I'm almost like, for you, caffeine might not be your friend. Most of the time, I wouldn't worry about it too much, but there's been a few where it's pretty significant. So,
and switching to decaf coffee, for example, fix it?
Yeah. So, so I love them and then for ongoing, if for some people, and maybe this is partially why I still like using it, but I do like the extra accountability. I don't like seeing a big spike. Now it's not common again that I'm going to see a big one just because I've been low carb for several years, but it is always eye-opening. Last year, Matt decided that we should get some cookies from somewhere. I won't say where. And my sugar stayed elevated for 13 hours. And it was so eye-opening. It'd been a long time, but I was like, those cookies were not worth a 13-hour blood sugar excursion.
So your pancreas was taken off guard, right?
Yeah.
It was sleeping.
Yeah.
And then finally, it's like, the security guard had to wake up, and I mean, Ben Bickman has shown a couple or done a couple papers where it takes a day or two for your pancreas to start waking up to respond.
Yeah.
So if you're eating those cookies every day, you might actually have a response to keep it down, but the insulin goes up to keep it down. And I'm so glad to hear you're measuring insulin levels among your patients. That's fantastic. But now I'm thinking, Matt, you're not wearing a glucose monitor, you're wearing a ketone monitor.
There is now a ketone monitor that we have. It's still in the box downstairs.
Okay, and you haven't started. Okay, because
yeah.
I know another doctor on the internet who will remain nameless has been using one for a while and really focuses, I think, too much on the measuring of ketones. But anyway, okay, so you don't have information on that.
No,
so
yeah. As you said, if you don't eat for 2 days, you're in ketosis. I think the natural state anyways is even if you just eat low carb, you will be in ketosis like first thing in the morning. And as long as you're feeling good and at your metabolic goals, it's just to help pinpoint and figure out what additional levers you can pull if you're reaching that plateau, or if you have chronic fatigue and you really you want to see if you can feel even better than just low carb. Do you need to target a beta hydroxybutyrate of 3 millimolars, stuff like that? I think if somebody's feeling good and they're improving and getting to their goal metabolic health, I don't want to mess up a good thing.
how can I help? Where would you be influential, or excuse me, Dr. Yancey here was on curbsiders. Are you familiar with curbsiders?
I am.
I get a call from my nephew, who's an internist in St. Louis. Eric, are you listening? Uncle Eric, are you listening? Will Yancey's on, and he hasn't. Oh, and then he mentioned my name, Will Yancey, because we've worked together for 10, 15 years. Now, curbsiders isn't going to ask me to be on just for whatever reason. So are you ready for Z-Dog and curbsiders and all the folks? And how do we get you into this world of doctors your age?
Well, I would say come on. Yeah. I was hopeful. I'll say as much. I'm very optimistic. I was hopeful that we would publish this paper, the rebuttal for the AAP article, and there would at least be some communication between the AAP, like them reaching out, just starting a discourse, which didn't happen. So you cannot go with the academic route. There's Mediterranean diet doesn't need advocacy, but low carb keto, if you look at some of these publications Laura was alluding to earlier, I leave that to an exercise to your listeners, because I don't want to call anybody out either on the podcast, but there's a lot of very highly influential academicians out there that publish obviously just biased things against low carb ketogenic diets. So I do think that getting our message out there through podcasts, and we have been on a variety of many excellent podcasts, but I think that is the next step, somehow breaking out of just the realm of low carb podcasts. Curbsiders is excellent. I listened to that almost every single episode when I was in residency, because when you're an inpatient, it had amazing information for both inpatient and outpatient too.
So I think there's a Duke connection there. So I'll see if I can make something happen. So the other person that it would be great if you haven't met is Nick Norwitz. Mm-hmm. I'm sure you're following Nick.
Yeah, we're work together on this last paper.
Fantastic. Okay. Awesome. Well, thank you so much for taking time to talk to me and sharing. So to my followers, I mean, these are the new generation of keto-friendly doctors and family even, and it's just thrilling to see you guys progress through the years. Thank you so much.
Yeah, thank you so much for having us on. It's always great talking with you.
Appreciate it.
Bye now.
Bye.
Bye-bye.
If If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.